All right, welcome everyone. My name is Carla. I am a diabetes nurse educator, and I am very pleased to be here with you all, and thank you all for joining us. Just a couple of reminders before we get started to mute yourselves. We will uh, accept questions at the end. We will have a question and answer at the end. And I am pleased to welcome everyone so that we can introduce our Screen and Treat program in collaboration, SDRI collaboration with Breakthrough and Sanofi. This just heads up that this presentation will be recorded, and at the end we will send it to anyone who has registered. Any links will also be shared with everyone at the end through the email, and it will also be in our SDRI YouTube channel. We will be talking about, again, our Screen and Treat program and just a little bit about Breakthrough Type 1 Diabetes Early Detection Pilot Program. It did begin in 2022, and the goal is to increase type 1 diabetes screening. The program aims to increase healthcare professional education and community awareness. As mentioned, it started in 2022 with only 2 clinics participating in the program, screening at only 2 locations. Now, so far in 2025, there are 8 new clinics, including SDRI. So we are very honored to be a part of these efforts. And once all the new sites are up and running, there will be 17 clinics screening at over 40 locations. Again, SDRI is one of them, and we feel honored and very excited to be a part of these efforts. Huge goal is to screen for type 1 diabetes in general, to reduce diabetic ketoacidosis at diagnoses, to connect individuals to clinical trials and FDA-approved therapies. And at the end, we will have a special guest speaker, Katie, and she'll be sharing her experience in having received the Tzield treatment. And I would like to introduce Dr. Alchuri, Swati Alchuri, pediatric endocrinologist.
Thank you so much, Carla, for that introduction and for setting the background. So we really appreciate you all attending today to learn more about the Screen and Treat pilot program for type 1 diabetes. And truly, it can only be a success with all our support and with your support as well. And so we will be discussing about reducing the burden of type 1 diabetes through early detection and intervention. We'll discuss the rising incidence of type 1 diabetes in the United States and globally, move on to talk about the benefits of screening, how to go about screening, and why screening really is important. It can improve outcomes and reduce complications, and we'll review the stages of type 1 diabetes, and then move on to discuss more about emerging therapies to help delay the onset of clinical type 1 diabetes. So why is screening for type 1 diabetes now all of a sudden so important? When you actually look at the global incidence of type 1 diabetes and looking at it from like 1960 to 2020, you can appreciate that the incidence is increasing dramatically over the years, not only in the United States, but also in countries over Europe and also in Asia. Currently, as of 2025, there are 9.5 million people worldwide living with a T1D diagnosis, and each year there are about 513,000 new diagnoses, of which 164,000 are in those between the ages of 0 to 14. So this incidence is increasing at a rate of about 2.4% annually. When you move on and look at just the stats within the United States, there are about 2 million people living with T1D, and each year there are about 52,000 new diagnoses. And of those 52,000, about 20,000 are in the pediatric population. And so the youth incidence is increasing at about 2% per year. So really what this tells us is that type 1 diabetes is not just a juvenile disease. It can occur at any age. And even though the peak incidence of type 1 diabetes diagnosis is between 10 to 14 years of age, a majority of individuals newly diagnosed with type 1 diabetes are 20 years or older. There is a significant burden of type 1 diabetes. So we know that individuals affected with clinical T1D can potentially have a shortened life expectancy. There are acute complications associated with this extreme glycemic excursion. So with hypoglycemia, seizure and coma are possible, which are incredibly traumatic for the individuals and also for their family members. Having hyperglycemia or high blood sugars can increase the risk of diabetic ketoacidosis or DKA, which we know has detrimental neurocognitive outcomes, increased risk of morbidity and mortality, and can also have a sustained negative effect on blood sugar levels over time. And if you have poor control of your blood sugar levels over time, that can then increase your long-term complications down the road to include end organ damage, including the heart, the kidneys, the eyes, for example. There is a substantial financial burden also associated with a clinical diagnosis of T1D, where it can cost $500,000 for one individual over the course of their lifetime. And even having one DKA admission can cost upwards of $30,000. So let's move on to talk a little bit about the natural history of type 1 diabetes. So about 50% of T1D risk is attributable to genetic factors. There are also environmental factors that can also contribute to a T1D diagnosis. So we know that certain infections like viral, bacterial, fungal can be associated with T1D development, as can certain dietary deficiencies like vitamin D deficiency. Now, if you have a first-degree relative with type 1 diabetes, your risk of developing T1D is 15-fold higher compared to that of the general population. And having a second-degree relative with type 1 diabetes puts you at a risk that is twofold higher compared to that of the general population. Now, let's say that you had a genetically predisposed individual who is then exposed to a specific damaging event, so be it metabolic, environmental, or infectious, for example. This damaging event in this particular individual then activates the body's security system, which is the immune system. Now, the immune system is supposed to help us fight germs and fight infection and supposed to protect our body. But in this particular setting, given the genetics and given the damaging event, the immune system actually makes a mistake and it starts attacking the beta cells in the pancreas that produce insulin. And once this process has started, it just progresses with time. And over time, with continued beta cell destruction, you lose the ability to be able to produce insulin sufficiently. And eventually, once you've lost most of your insulin production, will need lifelong intensive insulin therapy. Now, once this immune system or immune process has started, this immune activation, the body then also produces these tags or warning signals called islet autoantibodies. And these islet autoantibodies that develop as a result of this immune attack are not attacking the beta cells, so they're not involved in that. But what's great about these islet autoantibodies is that they can be detected in blood, and they are our warning signal that you have that type 1 diabetes is diagnosed. And so once you have two or more of those islet autoantibodies, you have a diagnosis of type 1 diabetes. And where you are in that process of the immune system attacking the beta cells over time determines the stage in which you are of type 1 diabetes. So type 1 diabetes progresses in 3 stages. And initially, once you have the development of two or more of those islet autoantibodies or those warning signals saying, hey, the immune system is now starting its attack, initially early in the process, you still haven't had much damage to your beta cells. So you're still able to produce insulin sufficiently. You're still able to maintain normal blood sugars. So this is considered to be stage 1 type 1 diabetes. And over time, as the immune system continues to attack those beta cells, you eventually start to lose some of your insulin production and you're producing insulin insufficiently. And now you're starting to have some mild sugar disturbances. So maybe your fasting blood sugar is a little bit elevated, or maybe your blood sugar 2 hours after eating is starting to go up a little bit, or your A1C is starting to creep up. So with these mild blood sugar disturbances and the persistence of these warning signals or islet autoantibodies, this is considered to be stage 2 type 1 diabetes. Importantly, individuals in these pre-symptomatic stages, so stage 1 and stage 2, again, have no symptoms, clinical symptoms of type 1 diabetes. So you cannot diagnose them based on symptomatology alone. Now, as this process progresses even further, you eventually lose the ability to be able to produce the insulin sufficiently. And now the blood sugars are high. And with high blood sugars, you start presenting with increased thirst, increased urination, unexplained weight loss, incredible fatigue. And it's usually at this point of a clinical presentation that the blood sugars are so high and we need to start lifelong intensive insulin therapy. And unfortunately, this is the stage where most of our pediatric patients are diagnosed. So this is considered to be stage 3 type 1 diabetes. And these individuals at this stage are symptomatic. Now, before we move on to look at this in a different light, I want to take a step back and review the definition of type 1 diabetes. So in 2015, the Endocrine Society, American Diabetes Association, and Breakthrough, which was formerly JDRF, amended their definition of type 1 diabetes to include the presence of 2 or more pancreatic islet autoantibodies, whether or not clinical symptoms of diabetes or any dysglycemia or sugar disturbances were present. So it really is the presence of 2 or more of these islet autoantibodies that gives you a diagnosis of type 1 diabetes. So now taking that information and looking at this diagram here, this is depicting beta cell function over time. So assuming that those 2 or more islet autoantibodies are present, early on in this immune process where you're attacking and damaging the beta cells, you still have relatively normal beta cell function. So your sugars are normal. So your fasting blood sugar is less than 100, your A1Cs are less than 5.7%. And even after you eat 2 hours later, your blood sugars are less than 140. So this is considered to be stage 1 type 1 diabetes. And as you can see, as time progresses, the beta cell function starts to diminish, more so because the immune system is continuing to attack these beta cells and causing beta cell destruction and death. And now you're losing the ability to be able to produce insulin sufficiently. And now you're starting to have some mild sugar disturbances. So your fasting blood sugar is going up a little bit, blood sugars between like 100 to 125. Your 2-hour blood sugar after you eat is starting to go up, maybe between 140 to 199, or your A1C is starting to creep up between 5.7 to 6.4%. And this is considered to be stage 2 type 1 diabetes. As this process progresses even further, you eventually lose the ability to be able to produce insulin sufficiently. And again, this is where individuals can present symptomatically. And this is where blood sugars can be as high as 126 fasting and 2-hour glucose levels after a high glucose load of 200 or higher, and your A1Cs are creeping up 6.5% or higher. So really understanding this progression highlights the importance of identifying individuals in the earlier stages of type 1 diabetes and the importance of screening so that we can educate patients about expectant clinical symptoms of type 1 diabetes, educate them about how to check blood sugars so that they can optimize their sugar control before the control gets bad and then they have an increased risk of long-term complications, so that we can tell them how to check blood sugars and intervene early so we can prevent them from presenting in DKA. But if we detect them in these earlier stages where they're pre-symptomatic, we can also identify if there are any clinical trials for which they may be eligible or any approved clinical therapies. How do we go about screening? Well, islet autoantibodies really are the strongest predictor, again, for detecting type 1 diabetes. So they can be present well before clinical symptoms of type 1 diabetes present. And they are proteins that are detected in the blood, and they signal that the body's immune system is attacking the insulin-producing cells in the pancreas. And there are 4 autoantibodies that are recommended to be tested for by the American Diabetes Association, and they include insulin autoantibody, IA2, GAD65, and zinc transporter 8. Now, these antibodies can be detected in the blood in low but sufficient titers on blood spots. So there are kits that are easy to do at home and they can be sent into the lab. Now, these kits are pretty sensitive. So if it detects 2 or more antibodies, that can be highly predictive of a T1D diagnosis. And again, these antibodies can be detected well before clinical symptoms present. So once you have 2 or more positive islet autoantibodies, the lifetime risk of progressing to clinical or stage 3 type 1 diabetes approaches 100%. Once you have 2 or more of these islet autoantibodies, There's a 5-year risk of progressing from stage 1 to stage 3, that's 44%, and a 10-year risk of progressing to stage 1 to stage 3, that's 70%. Now, the younger you are when these islet autoantibodies develop, the more accelerated your progression through the various stages of type 1 diabetes. And that's often why we see kids coming in at stage 3. And oftentimes, adults end up getting missed in terms of their diagnosis. So, about 40% of adults over the age of 30 who truly have a T1D diagnosis are misdiagnosed as having type 2. And the reason for that often is that because it is more slow in its progression in those that are older when these autoantibodies develop, a lot of adults don't present as being insulin dependent. They don't present in DKA, and they tend to go through their stages more slowly. So, should you be at a younger age, that rate of progression could be more accelerated. And should you have a specific genetic makeup, it could also be more rapid in its progression. Now, what about individuals who only have one islet autoantibody that's positive? Now, there are cohort studies in the pediatric population that show up to 50% of children who actually test positive for one islet autoantibody will revert to being islet autoantibody negative. Now, if IA2 is the antibody that is positive, that could indicate that there might be a faster progression. But if you have a persistently positive single islet autoantibody, there is a 10-year risk of 15% of progressing to a diagnosis of type 1 diabetes. Now, whom should we be screening? So, really, our screening should focus initially on first and second degree relatives of those who have type 1 diabetes. Interestingly, about 90% of individuals who have type 1 diabetes do not have a family history of the disease. And this really speaks to the importance of also general population screening. Next, here is really focusing on individuals who have a personal or family history of autoimmune disease. So, there are certain autoimmune diseases like celiac disease, which is a wheat gluten allergy, and Hashimoto's disease or Graves' disease, both of which are autoimmune thyroid disease, that if you have those conditions, you have a risk that is 2 to 3-fold higher compared to that of the general population of developing type 1 diabetes. It's also important to consider screening in individuals who have prediabetes or those mildly elevated A1Cs, and in individuals with type 2 diabetes, perhaps that are not responding to traditional therapy, and also individuals who have LADA or latent autoimmune diabetes in adults, and also gestational diabetes as well. Now, moving on to general population screening, this can be a fairly hard sell, but like I said, about 90% of individuals with T1D don't necessarily have a family history of the disease. Now, there are no generalized guidelines as to when to start screening individuals, but studies have shown that these islet autoantibodies can be detected as early as 9 months to 2 years of age. So there really is a push within the pediatric population to establish guidelines with the American Academy of Pediatrics to align screening with well child visits. So between the ages of 1 to 3, for example, when hemoglobins are being checked, and also between the ages of 4 to 6 and 9 to 11 when vaccines are being administered. So again, screening in those young ages, 2, 6, 10, may be optimal for detecting type 1 diabetes during childhood or adolescence. And 79% of children who do test positive for these islet autoantibodies will develop type 1 diabetes by the time that they're 15 years old. And we should also consider, as we had briefly mentioned, screening in adults who have a family or personal history of autoimmunity, also LADA or gestational diabetes. How do you go about getting screened? Well, you could go to a commercial laboratory such as Quest, LabCorp, or PDL to get screened, and that will involve a venous blood draw. But you can also get kits where you can screen yourself. So especially through our program at SDRI, we have a kit available that is free of cost where we can screen any individual 1 year and older and also those within the general population. Another option is through TrailNet, which will screen first degree relatives between the ages of 2 to 45 and second and third degree relatives between the ages of 2 to 20. And also the ASK program, which is based out of the Barbara Davis Center, which will screen patients 1 year and older. You do not need to have a family history of type 1 diabetes, and they'll also screen the general population. So how do we really justify general population screening? Well, the guidelines presented here were actually published in 1968, and they are widely adopted by healthcare professionals and policymakers to evaluate screening programs. And so an effective screening program satisfies 10 of these principles. So let's start with the first one. So identifying an important health problem. Well, we know that type 1 diabetes is one of the most common and consequential chronic illnesses of children, but it can affect anyone at any age. There should be an acceptable treatment for the condition. Well, before 2022, there really wasn't any therapy that we could necessarily offer to our patients to help delay the progression to clinical type 1. But now with the introduction of teplizumab, we have that option. And we'll talk about teplizumab or Tzield in a little bit more detail a few slides down. Facilities for diagnosis and treatment that are available. We have SDRI to be able to complete this. There should be a recognizable latent or early symptomatic period, so we understand the stages of type 1 diabetes. There should be a suitable test or examination. We know that islet autoantibodies need to be tested. This can be done in a laboratory setting or using kits that are easy to use at home or in the clinical setting. The test should be acceptable to the population. So this test, as we will review, involves a finger prick. The natural history of the condition should be understood. So although we don't really understand everything that contributes to the development of type 1 diabetes, we do know that it is an immune-mediated process which causes death of the beta cells over time. There should be an agreed policy on whom to treat as patients. We know that children and adolescents during their developmental years have the highest unmet need, but we cannot forget about adults who may also be misdiagnosed. Now, the cost of case finding should be economically balanced in relation to expenditure on medical care as a whole. We know that the lifetime costs for type 1 diabetes after onset in childhood are incredibly significant, and this is excluding the additional costs that can be associated with diabetes-related complications, and that the case finding should be a continuing process. So there are projects across the globe to really pilot strategies to increase diabetes awareness and promote screening. What happens in individuals who are screened versus those who are not? So let's look at 3 different outcomes. So one is using insulin. So individuals who are not screened and not identified in the pre-symptomatic phases of type 1 diabetes do require immediate insulin because oftentimes they are diagnosed in stage 3. Whereas if you identify individuals in the earlier stages of type 1 diabetes, they potentially could be eligible to receive teplizumab, which has been shown to delay the progression to stage 3 type 1 diabetes by about 4 years, so by about 2 years more than placebo. We know that individuals who have not previously been screened and identified within the pre-symptomatic phases of type 1 diabetes, about 20 to 50% of them, when they are diagnosed with T1D, they're diagnosed as a result of a DKA event. But with screening, we can reduce the rates of DKA by as much as 90%. We also know that DKA admissions are incredibly expensive, and if we're able to intervene early and prevent a DKA admission, we can obviously avoid the high costs. Now, we're not naive to the fact that discussing about screening, the actual process of screening can be incredibly stressful and anxiety provoking, not only for the individuals themselves, but also for the family members. Studies have shown that 70% of caregivers of autoantibody positive children in the general population report high anxiety, and 45 to 70% of islet autoantibody 10 to 15-year-olds report high anxiety. Now, studies also show that this anxiety will wane with time, but a lot of it is really critical that you have a very comprehensive medical team. So it becomes incumbent upon the providers to provide appropriate counseling, to provide appropriate education about staging, about what to expect through the process, and to answer questions and meet the family where they are. And this is really what we hope to accomplish with our multidisciplinary team, and also consider providing appropriate psychosocial support, so referral to behavioral health if necessary. Now, moving on to teplizumab or Tzield. This is the only FDA-approved treatment to delay the onset of pre-symptomatic type 1 diabetes to symptomatic type 1 diabetes. So delaying the progression from stage 2 to stage 3 in eligible patients. And so eligible patients include pediatric patients ages 8 and older and adults who have stage 2 type 1 diabetes. And so studies have shown that it can delay the onset, the median time to stage 3 progression by 2 more years compared to that of placebo in high risk individuals. And it can reduce the progression by about 70% over 5 years in some cohorts. It's given as a once daily infusion over 14 days consecutively. Usually it is covered by insurance. And we at SDRI are thrilled to say that we can give you the opportunity, should you be eligible, to receive therapy at SDRI. So really, truly, we believe this screening program can be a success because we are committed to early detection of type 1 diabetes and subsequent monitoring to help prevent complications like DKA, which is linked to poorer outcomes. Early detection can help provide time for education and counseling and better empowering our patients to manage their disease more effectively. We hope to also be able to reduce the stress and anxiety surrounding a clinical diagnosis of type 1 diabetes if we're able to detect you within the earlier stages of T1D, and also hope to identify individuals who potentially could be eligible for certain clinical studies or also for disease modifying therapies such as TZIELD. So we hope through our program to be able to increase awareness of early screening in high-risk individuals and also within the community, to centralize care within one institution from screening to monitoring to management, and then to collect real-world data to support a broader rollout and really promote sustainability of such clinics. So if you decide, which we hope you do, to get screened, we will initially focus our screening efforts on individuals in the clinic. So should you be coming to the clinic for pediatric care, for GDM care, or coming for research purposes, we would love to have the opportunity to screen your family members or answer any questions that you may have. And you can get screened at SDRI or through some of our events. And once you are screened, if you test positive for even one islet autoantibody, you will be followed closely in our SDRI screen and treat clinic. And the whole purpose of monitoring is based on your age, based on your risk factors. We can discuss with you about how often you need to get your islet autoantibodies checked, how often you need to get your blood sugars assessed, and based on your staging, what opportunities are available for you. Do you qualify for any trials? Do you qualify for TZIELD? All of that can be discussed within the clinical setting. The kits that we use are the Enable Biosciences kits, and it involves dried blood spot cards. So it does involve a small finger prick. It is approved for ages 1 year and older. It's free of cost. It tests for the GAD65, IA2, and insulin autoantibodies. So for 3 of the 4 ADA approved antibodies. The results usually will take 2 to 4 weeks, and we will communicate these results to you, even if they're negative. And if any antibodies are positive, 1 or more, we will confirm the positivity of these antibodies through a commercial laboratory such as PDL, Quest, or LabCorp. I just want to briefly introduce our clinical team. And mind you, this list is not exhaustive. There are so many people at SDRI who really are truly committed to making this program a success. But these are individuals with whom you may interact. So there's myself, there's Trisha Perky, who is one of our pediatric nurse practitioners who runs the pediatric clinic and is also involved in research studies. She could perhaps be performing screening in clinic, communicating results, and monitoring in clinic. We also have Carla Gonzalez, whom you met at the beginning of this presentation, who can also perform screening, communicate results, and monitoring. And we are incredibly fortunate to have Dr. Beth Braun, who is a health psychologist who specializes in diabetes management, who will be integrated into our clinical setting to help provide that psychosocial support. And then we also are very fortunate to have Dr. Fran Kaufman as our clinical consultant. So what are the next steps? We introduce the program to you. Where do you go from here? Well, we will be offering screening opportunities at the pediatrics clinics, or the pediatric clinics held on September 11th and September 18th. So if you are interested in having family members screened, please do bring them to those clinical visits, or if you have questions, bring those questions with you. We can also start screening in the GDM clinics, and for individuals participating in research, we will be present for screening at the Breakthrough T1D Walk in Santa Barbara to be held on September 20th. And please keep an eye out in the newsletter or for other community events at which we may be present, because we will have screening events held at SDRI and we'll be conducting events within the community as well. So I hope you can appreciate the rising incidence, both nationally and internationally, of type 1 diabetes, and really the importance of screening so that we can try to identify individuals in the earlier stages to help prevent severe complications and allow for earlier treatment. And now we have an FDA-approved therapy that does exist to delay the clinical onset of type 1 diabetes in high-risk individuals, and that is teplizumab or Tzield. And so with that, I'd really like to thank you for your attention. And SDRI would also like to give a sincere thank you to Sanofi for their support, because as Carla mentioned, we are very fortunate to have Katie here, who is on the behalf of Sanofi, is involved in their patient ambassador program and can really speak to her experience and journey with screening and also treatment with Tzield. And so with that, I will stop sharing my screen and let Katie take the reins.
Great. Thank you very much for having me here. So before I kind of launch into my little story, I have a little information about Tzield here for you all. So Tzield is a prescription medicine used to delay the onset of stage 3 type 1 diabetes. Tzield is for adults and children 8 years of age and older who have stage 2 type 1 diabetes. The most common side effects of Tzield include rash, leukopenia, which is a decrease in white blood cell counts, and headache. We've also learned that Tzield may cause serious side effects, including cytokine release syndrome and a decrease in your white blood cells, which can affect your body's ability to fight infections. It's important that patients tell their doctor if they're planning on vaccinations because Tzield may affect how well they work. So with that, yes, my name is Katie. I am from Pennsylvania. I live just south of Pittsburgh. I am the middle of three sisters, and I have been married to my husband George for almost 13 years. And we have two children, Alex and Logan. I've spent the last 20 years working as a physical therapist assistant in skilled nursing facilities. And I love the arts, and I've been really active in my local community theater for quite some time now. I'm also sponsored by Sanofi for being here today. And as I share my story, just remember that every person's experience might differ, and I cannot provide any medical advice. Your doctor's always that person you should talk to about questions around your health or any potential treatments. So, after being diagnosed with stage 2 type 1 diabetes, I infused with Tzield in December of 2023. And when I was considering Tzield, I didn't have anyone with firsthand experience to learn from, and I really wish that I had. I think in a lot of areas of life, experience is our best teacher. So I really hope that I can be the voice for you that I didn't have. And nothing would make me happier than knowing that by sharing my journey, you might leave here feeling more informed, encouraged, and prepared to advocate for yourself or for your loved one. And I also hope that you'll leave with an appreciation for the importance of screening and monitoring. And if you're eligible and have an interest in talking to your doctor about whether Tzield might be an option for you. I have no history of type 1 diabetes in my family. My own diabetes journey began when I was 18 years old and I started having some hormonal issues and sudden weight gain the summer after high school graduation. That was new to me. So I went to an endocrinologist that summer and she ran various tests and told me I was pre-diabetic. So years later, I also experienced gestational diabetes with both of my pregnancies. After giving birth, my A1C went back to normal and stayed there until about 2022 when it started slowly creeping upwards. And eventually, my doctor said to me, your A1C is getting too high, and we need to talk about what we're going to do about that. And at first, I pushed back. I just insisted I could get results by changing my diet. I've always been really active. I have an active job. I'm always on my feet, and I tend to eat well. So, having my A1C rise, it really surprised me. And at the time, my endocrinologist was treating my case as type 2. So I just really focused on what I ate and how I moved. And the diet and activity moderation helped for a while, but my A1C didn't stay down. It took about a year and it started rising again, even though I had kept up with all of my diet and exercise routines. So my endocrinologist suspected something else was happening at that time. My very first introduction to screening was when she ordered the screening for the type 1 diabetes related autoantibodies. It was just a regular blood draw at the lab, and I got the results pretty quickly. I did test positive for multiple type 1 diabetes related autoantibodies, which alongside of high blood sugar levels gave me an official diagnosis of stage 2 type 1 diabetes. That diagnosis came with just a roller coaster of emotions. Had been a really hard time for me, working so hard to address my A1C levels. And when I thought I had type 2 diabetes, and for a while, I saw my A1C levels decrease and when I made dietary changes. But I was really glad to know that I had done everything I could have, but I was really frustrated that I was now only getting the right answers, and it scared me. It just felt like I had an uncertain future at that time. So at that moment, my endocrinologist immediately told me about Tzield, but she said she'd only started learning about it and that she'd need to find out more. So in the meantime, I started researching Tzield on my own. And I was excited to talk more to my doctor about it, but she really never got back to me. So that was a little frustrating because she told me that I had a limited amount of time before I progressed to stage 3 type 1 diabetes, and then I would need to use insulin. But she didn't seem to have any kind of sense of urgency around researching ways to potentially delay that from happening. So in my mind, I felt like the clock was ticking and type 1 diabetes was just looming over my head. So it was really overwhelming thinking about what managing T1D would mean, and especially having young kids. And I just didn't know how I was going to deal with that. Eventually, she did call me back and we discussed Tzield, and she said, "Well, it's a 14-day infusion, and I'm not sure where you'd go for that. Probably an infusion center, but I have to keep researching." So I just couldn't go any longer without any kind of a clear direction. So I switched endocrinologists and I found one who was ready to just get right in and get started. I gave her the backstory and she reviewed all of my records. And she was also not familiar with Tzield, which was still fairly new at the time, but she was much more proactive about researching it. When I had my first in person appointment with her, it was in August of 2023, and she had already secured some information for me. She discussed Tzield's potential side effects with me just to make sure I understood the most common and the serious side effects of Tzield. So at that point, we both already knew that it might help delay my progression from stage 2 into stage 3 of T1D, which of course is when you typically need daily insulin. And I was ready to move forward, and was really happy to hear that my endocrinologist already had begun that process. And I felt really great after talking with her. I didn't have too many concerns about starting treatment. My biggest concerns were just to make sure the infusion schedule would fit with my life and how long and if I'd have to be away from my kids and what they would think about that. And I definitely didn't want to make it scary for them. So after I talked it over with my family, they were all very supportive and we were just pretty confident this we could make the infusion schedule work. So Tzield takes place over 14 days in a row with the daily infusions. And I received Tzield in 2023. My infusions were December 8th through the 21st, but I started preparing in November. The Tzield Compass team called me first and they were really on top of things. I spoke to the pharmacist and the Tzield Compass navigator, and they helped coordinate all the logistics and the paperwork. They educated me throughout the process about the treatments, and they answered any question that I could come up with. I was able to infuse at home with a nurse, although some people do go to an infusion center and others do a combination of both things. My doctor prescribed me anti-inflammatory, antihistamine, and anti-nausea medications that were part of my pre-infusion regimen, and I did take them as needed before my infusions. I was informed by my doctor that these medicines might help reduce the symptoms of cytokine release syndrome, which could be a fever, a headache, muscle and joint pain, or nausea. And the Tzield was shipped directly to my home, and the nurse set everything up and she administered the IV. And the first infusion did take a little longer than the rest to make sure I had no adverse reactions. That one was about an hour, but the rest were a little bit shorter and they were about 30 minutes. And throughout the infusion process, I really only experienced drowsiness, but of course, everybody is different. I didn't I chose not to work during my infusions also, but not because I wasn't physically able to. My nurse suggested, and I also agreed that because of the nature of my work, the safest plan would be to take the extra time off. And so that worked for me because I got a lot of baking done over those weeks, and that was just great right around the holidays. So after the 2 weeks of infusions, I kind of just celebrated with my family. It was Christmas time. We had, food and wonderful company, and just knowing that I really at this point had done everything possible to potentially delay my progression to stage 3. And I still feel good about my decision to infuse with Tzield, and I'm really happy to share with you all that I have not yet progressed to stage 3. So at this point in my life, these days, my primary focus is just on monitoring management. I have in person appointments with my endocrinologist every 6 months, and she monitors my A1C. And I also have just a regular finger stick monitor that I monitor my own blood glucose at home. And so far, my A1C remains in target range. I still stay active just at work, and I still do all the community theater I want to do. And I don't worry about all the things that come along with progressing to stage 3 of T1D. And I've had a lot of extra time to learn more about T1D. I like to read books and listen to podcasts. There are really great resources out there, and I can take it in small doses because it's really overwhelming if you try and just take it in all at once. So this has given me more time for that. I'm also a big proponent of screening, not only because of my experience with T1D, but because I work in healthcare and I've seen that information is definitely power when it comes to your health. It's really empowering, and it's important to know what's going on in your body. And it's important not to be afraid to find out, but that is easier said than done. I know how scary it is to think that one test could change your life. That's what made me scared to have my children screened initially. I did end up screening them toward the end of last year. And as of right now, both were negative for type 1 diabetes related autoantibodies. And I'm just going to continue to work with their doctor and go and see if rescreening is necessary. So I just really want to thank you all for listening to my story. I hope it helps more people learn about the risks of T1D and the importance of screening. And if you have been screened and diagnosed with stage 2 T1D, I encourage you, be your own advocate. Talk to your doctor about whether Tzield might be an option for you. And if anyone has any kind of questions about my experience, I am more than happy to answer them. I'm an open book. So ask away.
May I ask a question?
Sure.
Yeah.
Is this open to everybody or okay. Interesting. My grandson was diagnosed when he was 6 years old. He was diagnosed with type 1 diabetes. And he was eligible for TZIELD. He was administered the TZIELD, and this question and this issue is probably something that will probably be more appropriate to discuss on an individual basis. Long story short, I'm sure you all know how expensive the medication is. I think it's $15,000 just for one vial. And then over the course of a 2-week or 14-day administration, the total amount is approximately $200,000. My daughter, through her husband's insurer, received pre-authorization. The medication was administered, and then the pre-authorization was reversed. And so they've been battling the insurance company for 2 years, a company that continues to deny coverage. And what's most frustrating is that, Katie, as you said, I mean, this medication was groundbreaking. It's FDA approved. To uh, uh, delay the onset of the progression so that you don't have to deal with insulin infusion, exogenous insulin infusion is huge, is huge. So, I hate to sound, as a cynic about this whole process, but, it just is extremely disheartening when there are all these wonderful potential treatments, life-changing, life-saving treatments that seem to be battling, in insurance companies, or let me, I'll put more appropriately that insurance companies aren't on the side of promoting these treatments. So again, just unfortunate. It's an unfortunate experience that they had, and I don't know if any of you have had a similar experience.
Mm. Yeah, I'm very sorry that's happened. That's really not something you want to deal with, along with finding out your child has type 1 diabetes. Um, I mean, as far as that goes, I don't have a lot of insight as far as the insurance side of things, That's something that definitely I don't know if anyone else here knows anything about that or has dealt with anything in a similar situation with another patient.
Yeah, and I am both a retired RN and a retired
Mm,
attorney. And I have, tried my best to be an advocate, and it just seems to be, the insurance system seems to be not on the side of the rendering of this, you know, priceless, priceless,
yeah.
life-changing therapy.
Mm,
So anyway, thank you for letting me vent. I mean, I I think your experience has been amazing, and I wish you years of, just status quo and even,
yeah.
improved, um, levels, and
Yeah.
just to continue at the stage that you're at would, I'm sure, be uh, extremely gratifying.
Yeah. Well, I wish the same for your grandson. At least that would be something good to come out of that situation.
Yeah, actually, his C-peptide has went from zero, almost zero to an acceptable level, and the hope is to, keep that C-peptide, maintain some,
Hmm.
active, healthy beta cells. So he will hopefully at some point, the stars will align during his lifetime to
Mm,
have, take advantage of further research advances. And so that's basically the hope.
yeah. Hopefully, we'll cross our fingers.
Thank you. Thank you. Okay, I'll mute myself. Okay.
Thank you for
Thank
sharing.
you.
Thank you.
Any other questions?
Just wanted to pop in and say hi. I'm Roxana. I'm a pediatric CVCES in Arkansas. So with the Enable Bioscience kits, which I mean, I would love to have access to here at our facility, because one of the biggest barriers to screening is cost. And the unknown of it, because you can't seem to get a straight answer from insurance companies whether they're going to cover or not, and that brings a lot of hesitancy on both the patient side and the provider side. So they enable science bio kits when they can be subsidized to your facility, which some of these like grants are allowing through, like Breakthrough T1D and such. The limitation is that it doesn't test for zinc, right? So, it only tests for 3 out of 4 of those autoantibodies. And I don't know what like the statistically, like, if zinc is just one of the less common ones that we care about, or if they're just not one that usually just presents on its own. Because just anecdotally from what I see, we see a lot of just zinc single autoantibody positive kids that are just zinc. And I feel like that's, kind of a big limitation of those Enable Bioscience kits.
I agree that it is a limitation. The GAD, and you bring up a good point. Now, GAD, eye-attuned insulin autoantibody, especially within the pediatric population, tend to be just a little bit more prevalent. And then obviously when you're doing confirmatory testing, you can test for all 4 or 5 if you decide to use islet antibodies as well, through a commercial laboratory. As far as broader screening, the only screening that I do know outside of a commercial laboratory that would include all of them initially would be the ASK program. Now, even with Breakthrough, when they test initially, they only test for 2 autoantibodies, right? And if it's positive, then they'll do more of a broader screen. So historically, that has been proven to be successful.
You mean the TrialNet? Is that what you mean? The only test for
Through
the
TrialNet,
first? Yeah.
yeah.
Okay.
Through TrialNet, yes.
Yes, and Ask is great. Again, we use Ask for a while, like as here as a facility, but then we were kind of handicapped because they said it was actually technically research when we drew those labs for patients. So I think a big limitation of Ask, which is great, because it's completely free and it has gold standard assays, but it's the follow through, like patients need something easy, especially if you're trying to do something general population screening. You're not going to find hardly any families that are going to go to LabCorp or Quest to get those done, and actually, follow through with it. So it's just not a very easy, accessible program that people are going to follow up through unless they have the drive and motivation to do it, which at general population is just hard to find.
It's hard to find. And a lot of these pilot programs really are, that's one thing to assess, right? Like, is this, how sustainable are these programs? How cooperative are patients, especially within, you have motivation with those high risk populations, right? When you have a family history of type 1 diabetes or other autoimmune disease, you may be a little bit more inclined to go get screened to know for yourself. But if you are within the general population, you really don't have an inclination to do it. A lot of it is, we don't know, right? What are the barriers that are presenting itself? What would make the general population want to even go and get screened? So a lot of this we're still trying to find out, but you bring up really good points.
Yeah, I think it's really just going to have to be an AAP, and it's going to have to be like, USPSTF, like all those things are going to have to be on board before you see any movement towards actually this being effective at a general population. And that's really what it has to be, because even the high risk people, like you're not gonna, it's great, but you're not gonna find most people, because as you said, most people don't have any family history. So it's
Yeah.
a little bit frustrating and disheartening, I would say, until we actually get those recommendations. I just don't think there's going to be a lot of follow through.
Absolutely, I agree.
Sorry, I was just gonna ask one more thing. Like, and you may not be able to answer this, but it's specifically about TZIELD and like the pre-labs that you guys are recommending, or maybe just in your personal experience get. Like obviously you get a CBC and like a liver function. Do you guys routinely get like CMV and EBV before, like that's something that you standardly get?
Yeah, so there are recommendations through the Pediatric Endocrine Society about pre-screening labs and then how to monitor labs thereafter. A lot of it is very institution specific about how to monitor and what to obtain. But if you follow those guidelines, and then Sanofi hopefully should be coming out with some guidelines soon, but they do recommend getting HIV, EBV, CMV titers, both Sanofi and PES. prior to, in addition to some hepatitis levels as well.
Okay, that's good to know. Thanks.
And that article is accessible from the Pediatric Endocrine Society.
And you said it's in PES. I can just Google it and probably find it.
Yeah.
Okay.
We have a question in the chat. What are the years of screening recommended for higher risk individuals?
I guess I'm trying to figure out, like, is that sort of determining like the age of screening for recommended for higher individuals? And again, there are no established guidelines really around screening, but those antibodies can be detected as early as 9 months to 2 years of age. So you can start screening within the pediatric population. Now, if you are an adult and do screen negative, based on your risk factors, it may then determine whether or not you need to be rescreened, but you can screen as early as 1 year of age, I guess. Especially with these kids, because they are approved for 1 year and older.
I think maybe he meant like how many, like if you're in high risk, like, and you test negative for the autoantibodies, should you be following these kids yearly, like up to like a certain age, like age of 15?
It really is dependent on risk factors, as we mentioned before. So if you are a pediatric patient, for example, and you do test negative, but you do have a first degree relative that has type 1 diabetes, it is recommended to test annually to every 3 years until the age of about 18. So it really is dependent on your risk factors and what your labs show. And the next question is, hopefully that answered it. And if it didn't, please let me know. I see another question. I'm a lot of patient at Sansom, but my daughter's in her 30s is not. Is the only way she could be tested through SDRI through a screening event. So SDRI can provide screening free at cost. It is accessible, but your family member can get screened through a commercial laboratory. If they do, LabCorp and Quest, I know for sure, do have T1D autoantibody panels. That is a one-stop shop. You just order that one lab, and it will cover the 4 ADA recommended autoantibodies. So any provider can order that through a commercial laboratory, or you can, if SDRI is not an option, you can actually go to TrialNet on the website, or even through the Ask program, and request kits to be mailed to the home. And those are just some of the options. Those are not extensive by any means. I mean, exhaustive by any means. That is unfortunate.
Yeah.
So perhaps as a follow-up in the email, we will be sending some links. So perhaps we can send some links as to how to go about procuring some testing kits, or these websites as well. There is also a campaign through Sanofi called the Screen It Like You Mean It campaign. So there may be more information on that website as well, if getting screened through SDRI is not an option. Anything else? And if should further questions arise, we can easily answer those questions afterwards via email as well. Okay. Well, thank you all so much for your attention and for attending tonight. And again, on behalf of SDRI, we want to thank Sanofi, Katie for being present, and to thank you all for your attention and for some excellent questions. So thank you very much.
Thank you all for having me and for sitting around to listen to my story. I appreciate it, and I hope it helps somebody out there.
Thank you.
Thank you, Katie, for your wonderful story. Virtual hugs to you, and thank you,
Yes.
Dr. Alchuri.
Thank you. Thank you so much. I hope everyone has a wonderful evening.